Gleason and Alberto Viera, this guy. This is like a super special secret show that I think we advertise on the internet. So we're excited to have them.
And by the way, like if anyone thinks we have plans, we don't have plans. They just show up like little figments in our mind a few days before, and then they happen. It's great.
Well, the problem is when we have government officials on, we have to fill out their press forms, and we're like,
how do you do that?
I think we did get away with our show is unscripted
and live.
Anyway, enough about us. Amy, would you start by introducing yourself to our million loyal fans?
Yes. I'm Amy Gleason. I'm the administrator at the U.S. Doge Service, and I lead technology efforts at CMS for Dr. Oz, and I work very closely with Alberto.
I'm Alberto. I'm the Chief Health Technology Officer, and I work with Amy on all things tech.
Yes. Yeah, that's a pretty baller title, by the way.
Pretty good.
Yeah, I would probably give myself that title if I could. Okay,
nice.
What's our first question?
Yeah, I mean, I think both of you, everyone at this point in time. Go ahead. Okay,
go ahead. That's a legit one. Then I'll ask the non-legit.
I was going to give a real question.
Okay, go ahead.
Okay, I was just going to be like, how did you, like, both of you have, like, everyone these days, we can't escape it, has, like, a very personal story with healthcare that got you into this work. Like, how did you get into this work? We know a bit about your story, a little bit less about your story. So, like, give us, how did you get here?
Yeah, so I started out actually in nursing in the emergency room a very long time ago, where it does not feel like tech has changed that much since then. But I really started out realizing how important it was to have data at the point of care, because when patients came in scared and in pain and the doctors didn't know, patients couldn't always remember their history, and there were a lot of complications. That's how I got into technology, because I saw that technology could actually make it better. So, or at least in theory. So I worked on electronic medical records and billing, supply chain things. And then eventually my daughter was diagnosed with a rare disease when she was 11. She was a competitive gymnast and cheerleader, very healthy child until then. And then over a year and 3 months had kind of just seemingly not that significant symptoms, but eventually got to where she couldn't walk up the stairs, stand up off the floor. And obviously it got much more critical, couldn't do her gymnastics or go to school. And I realized at that point that ironically I'd been working on trying to make electronic medical records and data share. And my daughter didn't get diagnosed for a year and 3 months because nobody could see her data across all the different records. And if someone had seen it all, I believe to this day, somebody would have picked it up much faster, because somebody would have said, why is an 11-year-old going to the doctor this much? Just basically that. So that's really kind of what shifted me more into this passion area. I co-founded a company after that experience to help other patients like that. And then in 2018, took my first tour of duty into the government and came to try to help with interoperability. Then I was there for the COVID response, helping realize really where all of the holes are in the public health system. And then went back to private sector and then came back last January.
Yeah, awesome.
What about you?
What about me?
Chief Health Technology Officer.
So I was not in healthcare, actually. I did some work very early when I was a teenager, fixing and breaking computers and some consultancy that had to do with like somewhat with healthcare, but I never thought I was going to be working on healthcare. I came to government just to fix government at USCS. That's where I met Amy. I worked at the beginnings of what was the Medicare modernization with USDS, that now is making an effort we're working as part of Claims Core. And then in that journey, COVID happened. I started working with Amy on all things COVID. And then my daughter was diagnosed with type 1 diabetes. I have a daughter that was diagnosed with type 1 diabetes. We went to visit family in Puerto Rico. And then on the way back, it's like we ended up in the hospital, and she was hospitalized for a week. And then it was very weird because I was like building fire interoperability at my work. And then when I came to DC, I was like showing pictures of papers over telehealth cameras and basically trying to translate the record, just take the notes from the Puerto Rico. And then like we didn't create an EHR account back then. And then I called to create one. And I was so like, oh yeah, come stop by, give your driver's license.
Oh my gosh.
And I was like, I'm not coming back to Puerto Rico right now. I'm in DC. So that just became personal, right?
Yeah.
So since then I've just been doing this because it matters for everyone, for me, for my daughter. and
Yeah.
for the people we know. So.
Love it. Love it.
Wow.
So you two are like the chief architects, many other titles I'll give to you on this show, of the CMS health tech ecosystem. The interoperability pledge, many different names that we hear on the internet about this. So like, there's a lot of discussion about TEFCA and where that fits in. Is it complementary? There's like people on both sides. One of our really good friends, Michael Westover from Prov, he says, TEFCA's like liberal, and like the CMS health tech ecosystem is like Republican TEFCA. Which may or may not be true. But just tell me.
Not.
Like, is TEFCA just like,
Do not endorse.
is the bottom just rotting out underneath it, or is it about to fall out?
It's not about to fall out, Pat. So I think there's a lot of confusion about this.
A lot in there.
Yes,
That was an interesting analogy. I hadn't heard that one before.
Yeah, I mean, this is
I won't
potentially
comment
over a
on
lot
that,
of drinks.
But
Love you, Michael Westover.
but I think there's a place for regulation, but I think we've regulated healthcare tech to death from starting back in 2008 time period to now.
Yeah.
Almost 20 years we've been trying to regulate it.
Yeah.
And I think if you look at other industries that have successfully had tech revolutions, they haven't been because regulation made them.
That's
do it.
right.
It's because people needed things and people got together and figured out how to make it happen. So I think that's really where this came from. Alberto didn't say that he keeps getting drug into problems by me. He took over the point of care project that I started last time I was in government.
He told me it like that the first time we met, though.
Yeah,
He was
I
like, "Yeah,
drug him in. And then COVID, I was trying to fix problems. I'm like, Alberto, come help. And then came back again, and I'm like, hey, Alberto, come help. So there's a theme of this happening.
Yeah.
But basically, Arda was with us too in the beginning, and the three of us really sat down and said, why doesn't it work? Like, it should, on paper, it should work. Like, we've done all these standards things, we've done all these regulatory things, we've tried to incentivize, paid billions of dollars, but yet my daughter had surgery 2 weeks ago, and there were faxes, and there were paper clipboards, and there were, we can't take your insurance card electronically.
Wow.
She drove CDs across town. 2026. So it's like, despite all of that, it's just not working. So we basically tried to take a different stance and say, how can we just figure out how to pull people together, give a vision, and try to just drive industry to work together? That doesn't mean that it's in opposition to TEFCA, because it's a regulatory thing. It has to go through a slow process to try to bring the laggards on. So it kind of always has to be the base model, the floor. And then we're trying to just accelerate that and say, how can we test things? How can we get people to just connect and make it happen, so that hopefully we have less regulation we have to do, and just let it happen like other industries, and let tech do its tech thing.
Yeah.
So that was the idea behind doing this. And so we put out a big challenge and said, how can we do this in 6 months and 12 months, 1 year max? At least, I mean, not
I
really
love
solved in that.
Independence Day 2026
Yeah,
is the deadline.
Independence
That's
Day.
what I'm talking
July
about.
250th birthday.
2026.
It's a big day.
Maybe we'll fix healthcare interoperability on Independence Day.
So I think, will it be all fixed by then? No, but should we see a huge momentum? I think yes.
Yeah.
So we had 60 companies that started with us, and we have over 700 now that are working with us. So it's really created a big groundswell, and competitors working together on the things, working at like insurgents, incumbents, like everybody coming together. And so it's been really exciting.
It's like playing interoperability Legos.
Yeah.
It's like, I mean, there's like building blocks out there that have been regulated that work. Some people have been able to do certain things in closed hospital systems and stuff. It's like, but how can we unlock that, unleash it for everyone? So
Help
that,
stitch it together. Someone has to stitch it together, I think. Even
Well,
if it's a
Legos.
soft stitch.
yeah,
I haven't
so
heard
the
that one
interop
before.
Legos. You see?
Interoperability, like so like
We know our next graphic for the health tech.
we have, that's good. We need ideas. So we do this like all the time.
Yeah, our designer is running out of it.
She's like, yeah,
Legos the best.
yeah.
Maybe we can make a kit.
that would be incredible.
Let's make a kit.
Oh my
Nice.
gosh. Yes.
I'm sure AI and 3D printing can do it.
Absolutely. Yeah.
I feel like we could achieve that.
I think so.
We'll figure it out.
We'll figure it out.
Yeah.
So like, it's great that people have signed up. Company I work for normally signed up, a bunch of other, like, great. And I always kind of like my stance on interoperability was just like you. It was like, the tech is there. Like, there's no reason on paper why it shouldn't work. That's not the hard part. The hard part has very much been these like competitive dynamics. And I think generally when you put out like a regulation or a law, right, companies will comply with it to the legal minimum, right?
Yeah.
They're like, okay, if we get sued or if we get pushed on this, like, what do we meet the legal minimum? I am still very concerned about big incumbent players like playing to the legal minimum.
Oh, can I add to this?
Yes, absolutely.
Okay. So you were just talking about, and this is like a deregulation cat theory session.
Okay, we
Because I
love
am very pro deregulation over
Me
here.
too.
If you didn't know, Kat is pro
And Lisa is, as Jonathan Bush says, capitalist curious. So she's coming over too. Anyway, so
a whole comment letter on deregulation.
anyway, okay. So listen. But I did a lot of Googling, which is better. So regarding deregulation, okay. So like a lot of we always point to other industries that have kind of self-regulated or whatever it might be. And so the credit card industries are one example, right? They all get together. They all decide how information can go on their rails, right? What standards to use. We could also maybe talk about CPT codes, right? But like in all of the cases of which I'm aware in other industries, large mega vendors drove that forward. And in our industry, we are terrified of the large mega vendors who may or may not be named in this episode. So like, is it a problem to have large mega vendors? Are you worried about that? Or is there something you're doing to maybe encourage some of the smaller players to come up?
Yeah, so I don't know that worried about them is the right answer. I think we have to get everyone driving toward a common vision. So I think what I kind of saw, one of the things we were talking to people, we were setting this up, is one of the EMR vendors actually said, you're right. I think what we've just done is every time there's a reg, there's a giant Excel spreadsheet of checklists.
All the things
and we
have to
check,
do.
but nobody actually picks their head up and says, what is the experience for all the people that are doing this? What does this do to the patient? What does this do to the provider? And so I think she was saying, I think you're actually calling us to pick our head up and look beyond the check boxes. Which I think that's why we've tried to really rally around the patient story, because us and many others have experienced the horror of the experience in healthcare. And so I think when you rally around the patient, it's much harder for people to have something that they disagree with.
That's true.
So, by
you
telling,
have a common good.
that's one reason I tell my daughter's story with her blessing. She keeps calling me and saying, have you fixed healthcare yet? So I'm like, not quite yet, but we're working on it. But she grounds me in it every day. She tells me examples every single day of something that's broken. And it's hard not to be inspired by that. And she says, tell them it's broken. Tell them, make them fix it. And so she's wanting me to share, which makes it easier. But I think by telling that, I've had thousands and thousands of people reach out to me since I started telling her story. And having similar, I saved my grandmother's life because I used AI, or I figured out how to get these things to work together. I self-wrote a tool that did these, crazy stories. But I think we've been talking about patient empowerment for a long time. I think we're finally at a place where tech is allowing that revolution to happen. And patients are going to drive this to be different. And there's no company big enough to stop it. I don't think.
Well, I hope not. Because we talk about the patient story a lot. Well, even with what we were speculating a lot as you guys were announcing the ecosystem and the whole program, and we were like, what's it going to be? What's going to work? What's not going to work? Is it right? Our original assumption, because we're often right, never in doubt, sometimes wrong, that there was a lot of discussion about treatment and opening things up for operations payments. But if you focus on the patient and they can have access, that kind of solves a lot of problems for the more motivated group. So is that like your minimum acceptable outcome? Is that patient access is?
Well, I think we've tried to ground the whole thing in the patient. Our 3 main use cases we're tracking are all patient. There's no other use case we're driving in this first round.
Can you state them? They're kill the clipboard.
Kill the clipboard, which is the patient getting their data in an app they choose, and then being able to use a QR code at the provider's office to
not having to fill out the stupid clipboard.
No clipboard, no fax, no any of that. Just like here, just like you do at the airport, they take your data. Same thing in the doctor's office. The next one is once a patient has their data and their app of their choosing, to be able to use conversational AI. The powers of conversational AI. I can tell you stories for hours about. Morgan gives me a new one, I swear to you, every day, about how it's helped her. And it's really been transformational watching it help her over the last year, especially. So that inspires me. But I think we're going to see a lot more personalized information, because patients, a lot of times, when you go to Google, you get generic information. When you go to an AI, you get somewhat generic information, just more detailed. But now when you can put your records with it, you don't have to remember all that or know the prompts. It can just give you personalized recommendations. So that's important. And then the last one's kind of the same, but diabetes and obesity focus, straight up MAHA. but personalized. So based on your medical information, helping you achieve
Yeah.
those
Yeah.
goals, but personalized.
Yeah.
Very cool.
And there is also a through line across a number of the activities that CMS is doing in different areas. We talked about this with ABE as well, generally, right?
Right.
You have the access model,
Mhm.
you have the ARPA Age Advocate program
Right.
that's created. Like these things are like, there does seem to be like a path that you
Yeah.
can walk between them, which is kind of cool because one of-
Patience, affordability,
Yep.
being self-directed.
But
Well,
also
when
a
we
lot of
started
different
this last summer,
Yeah.
it was like, okay, how can we kick off this innovation? And so we kind of started the ecosystem, but knowing at that time we had a lot of conversations of, did the incentives come first or did they come later? Where are the sticks to get people to do these?
And
But we
incentives
just-
are also regulated. So
Yes.
But we
next
just took the
time-
approach to
Yeah.
start of like, let's get people excited about
Yeah.
solving a real problem
Yeah.
together.
Yeah.
And started that, but knowing we were already starting incentive conversations. So access model layered on top, rural health transformation
Right.
layers on top,
Yeah.
like
Right.
all of, and
Right.
the FDA working on how to better work with things to not stifle innovation. Things are changing so fast.
Yeah.
Yeah.
So it's
Yeah.
really pulled the thread and made it a great foundation for that.
Yeah.
The blocks.
The Legos.
The Legos,
the Legos.
Legos.
He's like, exactly. That's
Yeah.
why
We'll work
the
on it.
Legos.
We'll work on it. My youngest sibling is our graphic designer, and
Yep, they're
potentially
gonna do
something
this.
can happen there.
But I will say too, we did try to tackle some treatment and payment and operations things. So while patients are the main foundation, you also have to solve the problems for the providers and the payers.
Mhm.
And so we did a lot around trust with the treatment. We've had all these lawsuits and different
Yeah.
allegations. And so
Yeah.
part of that is building a provider directory where people can validate their identity.
Right.
And we can also vouch for them that they're a valid Medicare provider, since 90% or plus of
Yeah.
providers are Medicare. And then that can help when they say something's for treatment, then it should be for treatment. And if you think it's not, you should be reporting it.
Right.
And so that was that piece. And then delegated access with all these different AI tools and care coordination and value-based
Right.
care. And all these that a lot of people have a hard time adding them into their data sharing. And so
Yeah.
it's to help solve that. And then providers have a hard time getting claims data.
Yeah.
Mhm.
So letting them get that from payers. And in exchange, starting up some operational and payment use cases for quality measures.
Yeah.
And then clinical data that goes with the claim. So it kind of tried to scratch the itch of all the people to get them
Yeah.
motivated to come together.
Well, I wanted to talk about that specifically, the because like you were just saying, right? We all believe, and it's a very palatable to like the general public as well, that patients should get their data. Like
Give
as
me
you
my
said,
damn
give
data.
me my damn data. Like we can relate to that. It's easy to understand. If you're not like a health technology, health data nerd, right? Like you're like, yeah, I should get that. However, a huge amount of the work that we all do is just very like business to business, like provider to payer and back and forth, right? Technology companies, whatever it is. And like I guess the foundation of this, I question how successful we can be on the patient side, because it feels to me still like patient access is like an afterthought in the legal and regulatory underpinnings of health data exchange. Like, how do you feel about how do you thread that needle, so to speak? Because individuals care about getting their data, people with chronic conditions, people with serious conditions, but like the underpinnings are very business to business.
I will say, I think one thing is just like I was saying, I think the tsunami of patients wanting this is coming.
Yeah, okay.
So I will tell you, when I started my company, co-founded to help patients get their data and their families to have it in their providers so everybody share, I would go to fellow rare disease moms who were like, oh, this is such a problem, and trying to get them to actually just come do a very 3-step process.
Mm.
They would actually not often come do it, even though they knew they had this problem, they wanted the solution, but it seemed so hard.
Gotta fill out
Yeah.
so many forms.
Even when like Apple Health came out, and
Yep.
it was like a big, like, oh, you can connect your portal. It wasn't so easy because you had to know all your portal logins and they time out and pulling it all together. But now I think it's finally getting to the point that it's easy enough for patients to do,
Yeah.
especially the way we're trying to go about it with identity is the only thing you need. If you have your identity verified, you don't have to remember your doctors or remember your portals and all of that.
Yeah.
So I think that's the first part, is if it's not easy for patients and like so easy and they don't get something from it, like before you would just get your records and look at them. Like, this is really great. And it
Cool.
was kind of fun to read, but it was hard to share them still. It
Yeah.
didn't really give you
Yeah.
any insights. You had to go
Yeah.
Google all the pieces if you didn't
it's
know
a
about it.
Mega chart.
Now,
Yeah.
as soon as you get it, you just like get amazing. You connect to your sleep data and your steps and your heart variability. It's
Yeah.
crazy what you
Yeah.
can learn in a
Very
very
cool.
short period. So I think that's going to really change that. But I think the other side is this identity part is a really important to trust. I think that's the other big part with all this legal consent and all of these things. I think we're going to break through.
Right.
So like this is all like
the EHR's arguments is like it's not safe, and you're saying, hey, if we have modern identity verification, that argument doesn't fly anymore.
I think the other thing is us setting an example.
And
Alberto.
that's why we launched last week. So Medicare.gov now has the ability to use ID.me, Clear, and Login.gov as options to create an account, and basically you verify your identity. And then there were some steps you needed to complete just to link your user to an account. But now we can remove that and securely link you. So you come, you're a Medicare beneficiary, you create an account, and we verify your information, and poof, you come in and you're connected.
Love it.
Like my dad is a Clear user at the airport, and he has never been able to remember how to get into his Medicare.gov account. And they're moving this weekend or last weekend. And he's like, how do I update my address in Medicare? And I was like, oh my God, this is going to be a joyous moment. I was like, you already have Clear. Go to the site and you can just use it to log in. And he was so excited because he didn't have to try to deal with all these logins. And a lot of people don't even remember the difference between Social Security and Medicare. Like to us that have been around government, it makes sense. But people call the wrong number. They go to the wrong site. So having the same login, you can use them both, makes it so much easier.
Yeah.
And already, like the Social Security Administration, like if you create an account there, you use two services, ID.me or Login.gov.
Yeah.
So people were already going there, creating an account, verifying their identity. But then they were coming to us, and we were like,
create a new account.
Yet another username and password. So now they can just like keep using the same account.
Yeah, love it.
And that just reminded me, I need to do that with my dad when he we got login.gov, but I need to like sit with him when I see him next and be like, we're updating all of your you're gonna use login.gov or whatever it is. Like I need to update them on all of things. Good reminder.
Yeah. And we are also adding caregivers to Medicare.gov.
That's amazing.
That's what I need.
I'm very excited about that.
Tell our loyal fans about that. Caregivers is like one of the, I think one of the biggest, coolest trends right now.
Yeah.
Go for it, Alberto.
So, I mean, we launched the initial integration with ID.me, Clear, and Login.gov. You can still use a Medicare.gov legacy account for the time being, right? And we're gonna create the foundation now with this new identity where we can like securely connect to individuals. So if you come create an account, you say like, oh, I don't know, your loved family members say like, Kat, I want to give you access so you can manage my enrollment and help me out. They can like do this. Like it's like the Medicare like Facebook friendship.
Love it. That's what I'm talking about.
And then like you befriend there, and then now they have access to you have access to your account, and you can help them, right? To whatever level of permission they give you. So we're working
in their control.
Yes, and to define this, and then they can remove you if they so desire at any point in time, right? Or they can add, I don't know, your sibling or like some other family member.
This is great because Darshak is our team doctor. So like when this rolls out to commercial,
Darshak's gonna get a bunch of friend requests.
He'll hate it. Oh my God,
I'm gonna send.
He's already mad at us because like we all ask him for advice and then don't listen to him.
Well, I just saw a stat that 51% of users give someone else their login to log into a health account.
Oh, I so believe that. I believe that 1 million. I believe it. I'm sure it's more. The other ones are just lying about it.
But that's the reason now we're doing this, so you don't need to do that anymore.
Seriously.
You can have like your cat account, and then like somebody can just connect you. And then also like if you have a family member that I don't know, may have dementia, may have like a condition that maybe they had an account they can no longer access, they cannot have an account anymore, right? They may be in bed, I don't know, something else, right? So the idea is now that you can also create an account yourself, verify your identity, and then there will be mechanisms, back office, 1-800-Medicare, when they can say, oh, Kat McDavid, they can check the information, and they could say, okay, this person has a power of attorney or something, and then through the more like paper friendly mechanisms that exist today, they can still connect you in the back end.
But it's still, you can
and
still
say
do
like,
it.
yes, you can
and that is
connect
an
it.
important theme that they're not every patient wants to be digitally enabled. And so as much as, I lived through my child who does,
right?
Like not everyone does. And so I think we have to make sure we meet people where they are. And so, people that want this, great. Some people want their caregivers to manage it. Some can do it themselves. Some might have to call 1-800-Medicare to have them help them. And some people don't want either. And they just want their doctor to manage their interoperability. They want Medicare on the phone. And that's fine. Like wherever people are, I think that's where we need to meet.
And you still need the same digital infrastructure,
Yes,
the
to
same
do all of
identity proofing, the same things like that, the same coordination. I think the same workflow changes at points of care still need to happen, right? And I
Yeah.
think, that's a really important difference of saying, like, if you want it, if you need it, it's there for you. If it's a caregiver, it's there for you. If it's your doctor just getting the right information, that should also be there for you.
And that's where that treatment case, for example, comes in. Is if you aren't doing it, then your doctor needs to make sure they're getting it. And so
That's
they may not have the things you have on your personal thing, but they can at least get all the clinical side, the treatment side.
Okay, so we need some.
Yeah, you've only asked serious questions. Kat has some probably really crazy ones floating around in her head.
Lisa's the smart one. I'm the funny one, in case you can't tell. So, okay. All right. So you've got this big initiative going on. Like when it first went out, like the signal threads were firing up like, oh, Kat, what do you think? Do you think this is going to happen? Because we just closed our eyes and jumped. And like kind of hoping it falls apart. So
we did hear that, Amy.
Yeah, no, I mean, various versions of that.
I'm not surprised.
Yeah, which is awesome, right? Because you're barreling ahead. But like what like, I don't want to say like dirty tricks. What detractors do you have and what's the argument? Because obviously you don't care, but I just still want to know.
So again, I don't honestly think people, when you actually put it in the patient story, are against this. I think people get so bent out of shape and wrapped around their axle on privacy and security and who's liable and what's the riskiest thing. And I think I've been trying to get people to flip from right now. If you query, like I had an example where my daughter went and her doctor queried through the networks and got all of this information. And then she went through it and she got 3 records back, which she has 51 portals now. So that to show you, she should have at least gotten 51 responses.
Wow.
She got 3. And so, I'm trying to dig into this and talking to people, and it's like, oh, well, we're scared to do that because if we accidentally release the wrong thing to a patient, it's outside of HIPAA. But the real problem is they're also a violation of information blocking if they don't give patients the data and the OCR patient right of access. So I think we need to flip the conversation to be more of, it's not better to give less information. It's worse to not give the information that's important. And if if somebody doesn't have all of Morgan's information, they are going to make a medical error. 100%. There's no chance.
Yeah.
It's way different than these other things everybody talks about. So obviously we need to be secure, private, do all the things. But we're at a place where we can do all of that. So we've been working on patient matching as part of this big initiative.
Yeah.
That's probably one of the biggest blockers is this whole patient matching and what counts as a digital right of access request.
Right.
And kind of getting into all of that. That's really where it seems like the rubber meets the road on patient access. I think the rest is more technology. Like, I mean, just to be frank, our technology in healthcare is not stellar. And so, we hear things on calls sometimes like, oh, 5,000 patients querying might take down my network. And it's like, oh, well,
that's a problem.
There's this thing called the internet and it handles a lot every day. And we need to figure out how to be the internet and not this
Wouldn't
broken
it be amazing
telephone.
if 5,000 patients actually did query?
Oh my God.
That'd be amazing.
Or 50 or 100 million.
Yeah.
There are 200 million people use AI every day to ask health questions.
Wow. Well, so that's
wait, how question about information blocking? How important do you think?
Not a day.
How important do you think enforcement is here? Because a lot of the stuff has been theoretical. Individual patients often don't have the financial means, the legal access to like sue someone for not releasing their records or whatever it is, or pursue legal action. Like the government is saying here, we are going to enforce this. Allegedly, it's coming. Allegedly, it's starting. Like, how important do you think that is as a push as well to accelerate the work you guys are doing?
I think enforcement is critical, but I also think patients don't really know how to tell when there's a problem.
Right.
So I think by putting these apps out that patients actually can see what they're getting and should get and not get, and making it easy for them to report right there and say, hey, I have 51 doctors and I only got 3, to be able to easily click a button and say, share my story. I think that will also help to start. I don't think there's a lot of stories being told, especially from patients, because they don't really know how. They don't understand all of these things and where to go. They're not in our world.
100%. Yeah.
Also, patients that are struggling with this are super overwhelmed too.
Yeah.
So we need to make it easier for them to report this, or I don't know, communicate it somehow. Like even in the same healthcare system, my daughter, she went to her appointment the doctor said like you gotta take some do some labs, go to the third floor or whatever, and then we went there. But it's like the EHR for
We
lab.
use a different EHR
It's
Yeah.
for
like
labs.
different, and
Yeah,
they were
amazing.
asking
stuff.
again for the
Amazing
same
choice.
driver's license for the same thing, and I was like, listen, I did your stuff,
Yeah.
and then like I already gave the parts down there. It's like, yep, it's different. You gotta give them to me again. More
Incredible.
photocopies, more scanning,
Wild.
and I was like, wow, this is insane.
Super uncool.
My favorite is when Morgan just went for her surgery. They said, we need your insurance card to copy. And she's like, oh, I only have a digital version. They're like, oh, that's all right. We have it anyway.
Why do you need it?
Why do you need it? Why did my God?
That's
So ask
amazing.
for that.
Well, hey, so we were just talking, Joe Grogan, who, is former DPC and Paragon guy. He likes us and has us on his talk show all the time, which is hilarious.
We're his unofficial correspondents.
Yeah,
for
I
Healthcare
feel
IT.
like we're in it. We're in it to win it. Anyway, we just his is not live, so we don't know when it's coming out. So it could sometimes. But we just had a conversation with him about privacy, and his thing was all like, is it that big of a deal? Are we already past that point? And like, I think we probably are in terms of the data already being out there and exposed.
I think the problem is that, like you were saying, there isn't as much of like a legal framework for anti-discrimination for things like
Yeah.
genetic or health conditions. It's not comprehensive. So
Yeah.
I don't care. I genuinely don't care. I would give you all my data right now. I just don't want to in the future be discriminated against because of something in my medical
Right,
record.
right,
Most people
right,
feel that way, right? But like we don't
Well, I
have
think
the
it depends on your situation.
Yeah.
I mean, once Morgan got diagnosed with a rare disease,
like, well,
she's like,
here I
take
am.
it all, fix it. Like,
Right,
find me a thing,
right.
like, do research and whatever.
Oh, right.
She
Yeah.
literally was fine to put it on the internet. And she honestly doesn't care about the future because there may not be a future if
Like,
she doesn't
it's
get the
critical
things,
for
right?
me
Right.
to
right,
live.
Right. Right.
So I think
Yeah.
you hit the people on that extreme,
They're
but
like,
then
whatever.
you hit people on the other extreme that are
Right.
very worried about it. And we have to,
Yeah, mental
again,
health,
meet
all
everyone
that
where we
stuff.
are. And so I think it is important that people, whether it's already out there or not, that's why as part of our conversational AI piece, we required the models that were just participating to put it in a private area
Mm.
and not train the models with the data unless the patient explicitly says,
Yeah.
like my daughter might say, do it, but
Yeah.
others would not.
Right.
And then we're making everyone get Karen or Dime certification. So saying that they're making the privacy and security very well explained to the patient in plain language, not the long, scrolly, clickable thing that nobody reads.
Apple, where you're like,
Yep, that's me.
7 pages.
And if you're going to open it up, it's like in the workflow at that moment in the clear, like, are you sure you want to do this
Yeah.
kind
Yeah,
of
this
thing?
is what that
Instead,
means.
right.
That's kind of awesome. That's fantastic. One of the other things we talked about with Joe was kind of what you're talking about with like, we should be more concerned about the patients not getting the data than potentially them
Right.
getting the wrong
Yeah.
one because of a mismatch, which whatever.
Yep.
I mean, I think we were talking with him about AI, right? Clinical AI. And it's like, oh my gosh, someone just hacked Doctronic
Right.
because they really wanted to and tried. And it's like, okay. But every day, the number of human medical errors made is like
lot.
significant. So,
Yeah.
I agree
lot.
with your point there that like there's a lot of harm that happens by not having the information. And does it outweigh the harm of potentially, the other Cat McDavid in America, wherever she's at,
Well, I will say that's one of my daughter's biggest pet peeves is when people say, like, well, what if it gets it wrong? What if the AI is wrong? She always says, I've been to many
of my
doctors
doctors
for
were wrong.
second
A
opinions,
lot of them have gotten it
and
wrong.
they give me 2 different answers. One of them is not right.
Yeah.
So she's like, this happens today. Humans make mistakes. AI is going to make mistakes. But
Yeah.
hopefully these models, we always say they're the dumbest they'll ever be today.
Mm.
So, they're
Good
going to
point.
keep getting better as we go forward.
Yeah.
I think on the patient matching thing, we've been leading a big patient matching effort also at CMS, because we're also going to be responding to patients, providers, and payers with claims
Yeah,
data.
Right on. Yeah.
And so we've been going through a lot of work to make sure. And when you actually
lot of work.
sit down and figure out a line of where the risk is, like, if you look at the probability of collision of people, and then when you combine enough elements, you virtually get to zero risk. I mean, it's never really zero, but
Yeah.
very, very small. And you have to look again back at that risk, I think, of not doing it,
Mhm.
Yeah.
comparing it to that. It's not just like in a vacuum. It's comparing to the alternative.
Yeah, I have one very not serious question, which is,
Thank God.
Alberto, what does it mean to be Gleason?
Oh my God.
What does that mean?
Oh my god.
So weird.
What does it mean to be Gleason? It's a subtle way to say try harder.
But Nice try. Try harder.
Yes.
Awesome.
We're gonna get shirts. We're gonna get
No, we
shirts.
totally
Amy-
along with our Lego set.
Amy
Oh my
is
God.
inspiring us all to try harder. Do a
Somebody
little
told me
better.
that I have serious mom energy, but it's like everybody in the car now and let's go.
Yeah, mom's
So,
hard.
So
maybe
it's like
that's it.
being Gleason has been a internal joke of the team for the past few weeks, so they'll see this online.
You know this, but Lisa and I are experts at making T-shirts.
We are.
Yeah.
Yeah.
So
I have
we
heard
can
that.
certainly, maybe we'll even sell them on the internet. See what happens.
Amazing.
Okay, all right, you guys. I'm out of dumb questions. Are you?
No, I mean,
Uh,
I think I could certainly find some more dumb questions. But anything else you want to share with
yeah, what
our
do you tell us?
millions of loyal
what's,
fans?
what's your like? I mean, I don't know if you guys know this. Everybody watches us.
Everybody.
Of
So
course.
you should probably tell them something.
Yeah.
I would say that
Gotcha.
that healthcare is a complex problem, and we're at the place where we need to stop talking about it and just do it. But to do that, we need everyone to come to the table and join forces. And you may not like everybody, you may be a competitor, but we have to fix this for patients. So I think if we can just get people to join our pledge, come in the ecosystem Slack. You have Slack for Modern?
They let me on.
That's crazy. Wait, what? I didn't know you were there.
Well, I'm on like the special
Oh,
one
no.
where they put the consultants.
Oh man.
But we have work groups, and I think people a lot of times, like I've heard from providers over the years, that they say regulation has determined things without us being in the loop, or
Right.
nobody asked us, and this doesn't work for us. They just give us all these extra documentation things. This is your chance. Come be part of the solution.
Yeah.
Whether you're a one person or a huge organization, we want everyone involved.
Yeah. Try harder.
Yeah.
Try harder. Try harder.
Try harder.
But I mean, if you don't show up, the conversation will be and the decisions will be made by the stronger
Yeah.
voices. So everyone needs to show up.
And
Yeah.
you talk about the big companies, they often come with a lot of people and a lot of voices. And so if you want to be in the room and counteract that, come counteract it.
They
And
do.
this- we're just
they do, but
scratching.
they're small. But to be fair, like they definitely do, and they definitely will. They have the money to do that. But also in the ecosystem, there are a bunch of smaller companies who have just decided this is really existential and important, and they have shown up and are doing a huge amount of
Yes.
work. So it's not just like I can hear like a pushback to that, which is like, well, they have money. Small companies
Are dedicating patients.
people.
We have
Yeah,
patients
are
in there.
doing
We
this,
have
yeah,
single
yeah.
dot practices.
Yeah,
we
yeah,
have
yeah,
everybody
yeah.
in there.
Yeah.
And that's the beauty of it, I think.
No, and I feel we're just scratching the surface on a couple things. There's still so much to fix. Like
Yeah.
medical devices data, still
Yeah.
like the next frontier. Like
Yeah.
there's so many other
Version
things.
1.0.
Yes,
Yeah.
I know. So show up and come because like there's more problems and we need more people to fix it. So
I think that's been the most exciting part is we've had people in the ecosystem say, this is so cool. Can we do more use cases?
yes.
Like, let's create more pledges. So I think that's been a resounding sign of we're on something.
That's
I would
awesome.
have patients in the working group. So
Yeah.
this
Yeah.
is like patient voices and everyone's voices are
So our message is come join us and try harder.
Yeah.
Yeah.
Or you're gonna get Gleason.
Awesome.
All right.
Thank you guys
Thank
so
you guys
much.
for
Thanks for
joining
being
us.
here.
Awesome.
Thank you. It was
All
fun.
right. We'll be back tomorrow with some more shenanigans. and
Yeah,
lots of
we'll see
people,
what
and
happens.
We'll see what happens.
We'll see how the night goes. It might be rough. I
Yeah,
don't
we never know. We
don't
might
know
not
what's gonna
show
happen.
tomorrow. We'll see.
Yeah, no, we'll be here.
Okay. All right.
Quality is variable.
That's it.